My name is Christina Huff, and I'm a student nurse at Cedar Crest College. My evidence-based poster and paper topic is reducing ventilated-associated pneumonia. My clinical question is, for mechanically ventilated patients, how does head-to-bed elevation compared to supine positioning affect the risk of ventilated-associated pneumonia? I'm interested in this topic because my father was in the ICU last year, and I directly observed the nurses having his head-to-bed up, which then he did not acquire pneumonia. The purpose of this is to examine whether head-to-bed elevation of 30 degrees or above for mechanically ventilated patients can positively reduce or even eliminate VAP, which is ventilated-associated pneumonia. What is critical about head-to-bed elevation is several studies demonstrate that the mechanically ventilated patient with a head-to-bed elevation between 30 to 45 degrees experience less ventilator-associated pneumonia. It has been shown that intubation increases bacteria in the oral cavity as well as gastrointestinal reflux. The studies show patients in a supine position are at greater risk for aspiration of these bacteria, which then increases the incidence of VAP. VAP continues to be costly and a serious problem in healthcare and hospitals today. The incidence of 40% of all healthcare-related pneumonia is related to VAP, and it is estimated at a cost of $1.5 billion in healthcare costs. As a nurse, we could adhere to the evidence-based practice of regarding to head-to-bed elevation, which then can reduce the cost as well as improve patient outcomes. The search engines that I used for this subject is CINAHL, PubMed, ResearchGate, and Google Scholar. The limitations that were used were dates of 2007 to 2015, free full tests, as well as United States. Then I was able to narrow down my researches to my 3 top articles which related to my PICO question. The article from McCoy, Fields, and Kent is a non-randomized 2-group control study. The purpose of the study was to evaluate the effectiveness of practice changes in the emergency department to prevent incidents of VAP. According to the study, using head-to-bed elevation and related measures in the emergency department, and not just the ICU, reduced incidence of VAP by 83%. In this study, head-to-bed was part of a larger VAP reduction bundle that also included oral care and suctioning above the endotracheal tube. The second article by Wigerman, Katowski, Davis, is a randomized controlled full factorial study. This purpose of the study was to determine the impact of patient migration on the bed angles of head-to-bed elevation between 30 to 45 degrees. The results showed that the head-to-bed is elevated at both 30 and 45 degree articulations. Patients migrated towards the bottom of the bed, which then in return the torsal angle fell below the recommended level. The third article by Wolkin, Woodruff, Smith, Albert, and Douglas is a randomized prospective cohort study. The purpose was to evaluate the effect of continuous monitoring using visual bedside display and audible alarms that nurses adhere to head-to-bed elevation above 30 degrees. The results showed real-time continuous monitoring of head-to-bed elevation using visual displays and audible alarms was a feasible intervention and improved head-to-bed elevation adherence by 2 to 3-fold. The study also examined whether intermittent checks of head-to-bed elevation by nurses were accurate, and the results showed that nurses overestimated the adherence by as much as 25%. These studies also recommended 4 items. 1, head-to-bed elevation of at least 30 degrees should implement that in all patients that are intubated in every aspect of the hospital. And that is by McCoy, as well as all nurses should be trained on head-to-bed elevation for intubated patients. Patient migration should also be controlled by maintaining proper dorsal angle adherence when the head of bed is elevated, and that was by Wigerman. The next recommendation by Wolkin is visual displays and audible alarms should be used to monitor adherence to head of bed elevation in intubated patients. My conclusion is during the research and critical appraisal of the evidence, it became clear that though head of bed elevation is effective in reducing VAP, there are several other factors that affect head of bed elevation adherence that result in nurses not implementing proper head of bed elevation or patient dorsal angle. Thank you very much for watching this video. I can't wait for your comments.